Great, I think we'll go ahead and get started. So good morning, good afternoon, and good evening from wherever you're joining us from. My name is Liz Colway, and I'm the Director of Community Building and Digital Engagement at the Sabin Vaccine Institute, which hosts the Boost community. Again, I'd like to welcome everyone back on behalf of the Boost community and the World Health Organization to the third session of the COVID-19 Recovery for Immunization Programs Fellowship, which will cover closing immunity gaps and recovering immunization programs through reducing the number of zero-dose children. Next slide. Before we get started, I wanted to go over some logistics for today's session. First, if you would prefer to listen to the session in French, we encourage you to select the interpretation button in the meeting controls at the bottom of your screen. You should see a globe icon. We've also included some step-by-step instructions on the screen on how to access interpretation either through your computer or mobile device. Next slide. During the session, you can engage in dialogue with your peers and session facilitators through the chat box. We also ask that you use this forum to ask questions throughout the session as well. Once we get to the question and answer section of today's session, you may raise your hand to voice over your question, and that is if time permits. Finally, please remember to rename yourself, so your first name, family name, and then country, so that we can record your attendance for today's session. As a reminder, and we'll note this probably several times throughout the session, we are recording in both English and French. So these recordings, along with today's presentation in both languages, will be provided to attendees by the end of the week via email, and will also be posted to the Boost Learning Group in the Resources tab. Next slide. So I'm joined today by our session facilitators, Samir Sidar, who's the Medical Officer of Program Strengthening for WHO's Essential Program on Immunization, and Nicholas Danielson, who's the Senior Immunization Specialist at UNICEF headquarters. Next slide. For today's session, we'll first go over the strategic proposal and case study template that we've talked about in previous sessions. We'll then reflect on some key takeaways from session 2, and then spend the bulk of today's session diving into the main topic, which is reducing the number of zero-dose children. At the end of the session, we will save some time for Q&A with the audience. So again, I do encourage you to share your questions in the chat throughout the presentation. Next slide. With that, I'm going to hand things over to Laura to go over that strategic proposal and case study template. Over to you, Laura.
Thank you, Liz. And hi, everybody. This is Laura here. I know that many of you have been asking about the strategic proposal and case study template that we discussed. And as part of some of the earlier expectations we had for the fellowship, we said that after each live session, fellows must work on their strategic proposal. And what we've been doing so far is waiting for you to, I suppose, learn some key aspects of the fellowship and learn some new approaches and strategies before you begin this. And from next week, we'll be expecting you to work on this proposal. So in the next slide, I'm going to explain what this is going to entail. So we have mentioned previously that there's 2 tracks. So we have track A, which is for those to develop a strategic proposal for implementation. What we mean by this is that for those of you who want to implement activities for COVID-19 recovery, you should write a prospective strategic proposal outlining what activities you plan to implement. Now, we know that there are many people who have already implemented activities, but I think one of the things we know is that we don't have very clear documentation of what was done or how things went. So then we are also offering a track B for those of you who have already executed a COVID-19 recovery plan or activities, and you don't have any plans to carry out further activities. So if this is your case, then you should write up a retrospective case study documenting what activities you implemented to help with recovery of your immunization program as a result of COVID-19. So there we have 2 tracks, track A, track B. And in the next slide, we've developed a template that will help both tracks to document what they want to do. And there will be 6 sections covered, whereby we'll be asking participants to share their background and context, the objectives and justification for carrying out this proposal, the methods used, a budget and timeline, and the outcomes. So this is an overview of kind of what the template will look like, and we're going to share that with you in the coming days. We just are doing, we're going to make sure that we have input from everybody and then share it with you all. And then from next week, then we will hope that you will begin setting out some of the key aspects within the template. So with that, we have a little poll question in the next slide. So what we want to know from you, based on track A, which is writing a retrospective or a prospective plan, or B, a retrospective plan, what do you plan to submit? So if we could start the poll, then we could see which of the two things you're planning to do. Okay, so we seem to have. We'll give you guys another few minutes.
Yeah, Laura, I just want to confirm you can see those results that I'm sharing.
I can, yeah.
Great.
I can, yeah.
Great. We'll just wait, give everyone a few more seconds to respond, and then we can share out the results.
So what we're seeing so far is that, okay, over 50% of you have participated so far. We're nearly at 70%. So when we get to 70, I think I'll stop the poll and then we can see what everyone's saying. But it's a little bit of a split, some of what we would have expected. But great. So what we're seeing is that 2/3 of you are planning to write a strategic proposal, a prospective one going forward, looking at what you plan to implement, whereas 20% of you are looking at or considering documenting past COVID-19 strategic plans. And then some of you still have to think about which option is going to suit you best. So please, when you're considering that, take into account what will be best for you and also for your immunization program.
Great. Next slide.
Next slide.
Great. So we wanted to thank everyone again for those who posted on the Learning Group Forum last week in response to the question, which aspects of the first two sessions are most relevant to you for recovery of an immunization program? On the next slide, we've showcased some of your responses. On the whole, most participants noted the importance of both integration and life course immunization in your work, as you can see on your screen. In some cases, the responses were also dependent on country or regional context. In the case of Dr. Aminu, who notes that he aims to create a pilot immunization program focused on integration and life course in his country of Nigeria. And I don't know, I'll hand it over to Laura if you wanted to summarize some of the French responses.
Thanks, Liz. I think based on the French responses, there was a lot of interest or recognition about the missed opportunities for vaccination strategy, and also catch-up vaccination, which is, you know, they found that was more or mostly relevant for catch-up and recovery. However, Mr. Lazar from Chad, he described the MOV strategy and how it was very important, particularly in the African context. We see a high proportion of MOV in those countries, but also it's important to note that Chad was one of the first countries that actually carried out the revised MOV strategy, and the publication of that is available online. I'll put it in the chat. Thank you.
Great, and just a quick reminder, I do encourage you to visit the Boost Learning Group to post your own responses and to comment also on your peers' responses as well. In the Learning Group, we have active resources section, which I referenced before, where you can find session recordings, presentations, and Q&A from each session in both English and French. So with that, I'm going to hand it back over to Lara to just do a quick recap of last week's session. Over to you, Lara.
Thanks. Next slide. So last week we covered life course integration, and in the next slide we're just going to go through some key takeaways. So I think it's important that for both life course integration, these are an integral part of IA 2030, and this is the global strategy for the next 10 years that has or will become part of regional and country level strategies. So many of your countries will be adopting or have adopted approaches related to IA 2030. This is the Immunization Agenda 2030. Also, last week we discussed how both life course integration are strategies that encompass the aspects of this fellowship in terms of closing immunity gaps and recovering immunization programs, and also strengthening routine immunization and building back better and building resiliency. So then in the next slide, in terms of life course, we know that the key takeaway from the life course discussion we had last week was that the life course approach to vaccination extends the benefits of vaccination across an individual's entire life. And also there are key considerations that you have to take into account when transitioning to a life course approach to vaccination. Next slide. And then when it comes to integration, integration can have different objectives. We discussed that there's many different aspects of integration, and also the terminology we use for integration is very important in terms of, we know that integration happens at many different levels, and also that many aspects of our programs are already integrated, but sometimes we're talking about the co-delivery where we deliver multiple interventions at the same time. We also know that integration can increase coverage of immunization by reducing missed opportunities for vaccination, and it can also increase coverage of other health interventions. However, there are potential benefits and risks of integration that always should be taken into consideration. So these are some of the key takeaways, and if you have any more questions, you can pop them in the chat.
Great, I think we can go to the next slide. And then I think it's over to Samir.
Thank you, Liz. Can we go to the next slide, please? So what we're going to do is we're going to begin with a poll question. And this is just to give us a sense of where everybody is on their understanding at baseline right now about the zero-dose strategy. Can we launch the poll? So the question is, what is the objective of the zero-dose strategy? Reduce the number of children who lack DTP1, improve coverage of birth doses, or improve coverage and equity by fully vaccinating the most marginalized children. We'll let the poll go on for a while. We're about 15%. And I will be honest with you, I'm not going to give you the answer to this immediately afterwards. We're just going to use this as sort of a baseline to understand where you all stand. And then we're going to ask this question at the very end of the session to see if people's understanding has improved. And we will give you the answer at that point in time now. We're at 56% who have participated. And we will similarly wait till we get closer to 70%. I think we're close enough to get a sense of it, so we can go ahead and end the poll now. So you can see that we have a fairly even split across the three answer choices, and just a few people who said they don't know. At minimum, I hope the people who don't know will no longer answer that at the end of this session. So again, I'm not going to give you the answer right now. We're going to go ahead with the session right now, and then we'll ask the question again later on. So we can stop sharing it now and move on to the next slide. So to begin, we need to first go over some basic definitions. First of all, zero-dose children. What does that mean? Zero-dose children are children that have not received any routine vaccines. And the indicator we use for monitoring zero-dose, at least the indicator that we use at the global and national level, is lack of DTP1. Another term you need to understand or learn about is zero-dose communities. This is a relatively new term. It refers to communities with a high proportion of zero-dose children. So communities in this context can be based on geographical or socioeconomic attributes. So this is an important thing to remember because we tend to think of communities in terms of geography, such as villages. So if you have a high proportion of zero-dose children in a village, you can consider that a zero-dose community. And I think that makes sense to everybody. But you can also define a community based on the socioeconomic factors, such as ethnicity or religion. So if an ethnic group has a high proportion of zero-dose children, they can also be considered a zero-dose community, even though those children are not necessarily clustered in an area and might be dispersed all across the country. It's also important to remember that zero-dose communities, although it's a relatively new term, it's not necessarily a new concept. It's very similar to the concepts of mixed communities, marginalized communities, or neglected populations. They're almost synonymous. And in fact, I tend to interchange the term missed communities and zero-dose communities. And in this presentation, I'll often refer to as missed communities because I think it's conceptually easier for everyone to understand. Next slide, please. So the question is, why is this session part of a COVID recovery fellowship? Or in other words, how can addressing zero-dose help with COVID-19 recovery for an immunization program? Next slide. Well, to answer that, we need to understand the trend in global immunization coverage. The line graph on the right shows DTP3 coverage over time from 1980 to 2020. And in 2019, before the pandemic, DTP3 coverage was at 86%. Now, if you look at the horizontal bars at the bottom, you can see that this 86% coverage equated to 19 million children not receiving DTP3. And among those 19 million, most of them, approximately 70%, were zero-dose children. So even before the pandemic, we knew that addressing the zero-dose issue was critical to achieving progress in global immunization coverage. But then the pandemic came and exacerbated the problem. So in 2020, DTP3 coverage dropped to 83%. And again, I'm back at the line graph at the top. And that's the lowest level we've had in global immunization coverage since 2009. Now that number, going back to the bottom again, the horizontal bars, in 2020, the number of children not receiving DTP3 increased to 22.7 million. And almost all of that increase, in fact, 95% of that increase was among zero-dose children. Because that increase was almost exclusively among zero-dose children, it's essential for us to recognize the connection between immunization recovery because of COVID and the zero-dose issue. Next slide. The increase in zero-dose children was not geographically isolated. So this graph on the right shows the number of zero-dose children by WHO region. The larger the circle, the larger the number of zero-dose children in that area. And as you can see, from 2019 to 2020, all the regions saw an increase in the number of zero-dose children. The African region saw an approximate 10% increase, but the Southeast Asia region saw over doubling in the number of zero-dose children. Next slide. So a question, if you can put it into the chat, open to all of you. So in addition to the coverage and recovery issues that I've already mentioned, why else do we want to focus on zero-dose children and missed communities? What other issues are essential for us to appreciate the importance of this topic? And if you can put in to the chat some of your thoughts as to why you think zero-dose is important. So Dr. Sophia from Pakistan has said it's risk of outbreaks. Dr. Mita talks about access to immunization and trying to get people into the system. And now we're getting a flurry of answers coming in here. There's healthcare and economic burden, mention of preventing outbreaks again. So I think in service utilization, I see that flying through there. So next slide, please. I'm going to go over some of the three main concepts, which I'm seeing through the chat that's flying through here, that you are capturing all three of these concepts as well. So the first issue is the equity issue. Zero-dose children tend to live in the most marginalized communities. Next slide. There are three settings where we know there tends to be large numbers of zero-dose children. There's remote rural areas where it's difficult to access children, urban poor areas where children are difficult to track, and conflict-affected areas where it's dangerous or impossible to send in vaccinators. Now, in addition to these settings or contexts, there are gender-related barriers that are cross-cutting, that's a cross-cutting theme across all of these settings. Next slide. In the remote rural settings, there are higher marginal costs to reach these populations and challenges with recruiting, retaining, and motivating health workers. The long distances challenge already stretched cold chain supply systems. People in these communities have limited sociopolitical power, which affects their ability to advocate or access health services. And the data on these populations is often incomplete or underutilized. Next slide. Urban areas are becoming particularly challenging for immunization. Their high population density increases the risk of disease spreading, but there are also multiple additional challenges for the urban poor. They often face social distancing and discrimination. Residents of informal settlements fear encountering public authorities and avoid getting care from the public sector. Immunization programs may not be designed to provide services to these communities, especially if they are informal settlements. Insecurity in these areas may limit access for communities, and there's often multiple providers and stakeholders, but there's a lack of partnerships and coordination. And then the data in the urban setting is often inaccurate, especially when disaggregated by community. Next slide. Conflict-affected areas have multiple challenges that affect our ability to reach zero-dose children. Violence and physical force create disruptions to infrastructure and supply chains. These challenges are exacerbated by the loss and migration of healthcare workers. Even when healthcare workers are available, there are challenges of being able to provide services in some areas because of the insecurity and because of displaced populations who are difficult to track and find. Next slide, please. So for the chat, I want to expand a little bit more of the discussion about the gender-related barriers that I briefly mentioned earlier. How do gender-related barriers contribute to the zero-dose problem? And you may recall from our first session, we had talked about we were going to try to show how gender plays a role in all of our topics. And so I wanted to just expand a little bit more into it related to the zero-dose issue. So there's a mention here by Dr. Adora Isabella Otis about there being too much house chores. So there's the additional responsibilities that the mothers may have. Maybe the lack of female vaccinators in a conservative community. Travel limitation is mentioned here as well. Discrimination in rural regions. So similarly, I think to the last question, lack of mother's decision power, we're capturing a lot of the important concepts here that I'm going to go over as well. And I would encourage you, even as I continue to speak on the next slide, to continue to share your thoughts here, because I think there's lots of interesting things being pointed out here that's good for the whole community to see and take part in the conversation. Next slide, please. So it's important for us to understand how gender influences immunizations because it affects the inequities that we face in our programs and the zero-dose issue as well. Mothers who typically are the primary caregivers are limited because of their perceived lower status in some communities, and that affects their ability to act. They face physical and time barriers to access immunization services. They sometimes lack health literacy, and they often experience poor service quality, which may defer them from seeking health services, but may deter them, I apologize there, may deter them from seeking health services. But the other thing I want to bring up here is the importance of the fact that the gender-related issue is not just about the mothers and the caregivers. There's also an issue about the health workers. There are gender-related barriers that the health workers face all the time. Females are 70% of health workers, but they're only 25% of the senior management. They have limited decision-making authority, and we often underestimate how their own security challenges affect when and where services can be provided. The important theme I want to capture here is that the gender-related barriers are really an issue that permeates throughout the whole immunization program system. So it affects, to a certain extent, the beneficiaries, definitely the caregivers, definitely the health workers, up to the management system as well. And we need to be cognizant of it as we go through making improvements in our programs and trying to address the zero-dose issue. Next slide, please. So another issue that we need to focus on related to zero-dose children is that related to primary health care. Zero-dose communities are not just missing immunization services, but they often have no regular health services in general. Next slide, please. So when we look at who are the zero-dose children, 2 out of 3 live below the poverty line. The zero-dose children are 47% less likely to have a mother who received antenatal care, 47% less likely to have a mother who had institutional delivery, and 33% less likely to live in a household with safe water. The real ambition of the zero-dose agenda is to use our immunization programs and immunization services as an entry point, or in other words, the tip of the spear for broader primary healthcare services to enter these communities. And this further highlights the importance of integration, which was the major topic that Laura had discussed last week. Next slide, please. And then it was mentioned by many of you earlier too, the other issue related to zero-dose communities is the issue related to health security. We worry about zero-dose children in these mixed communities as they're particularly vulnerable to outbreaks. The pandemic has made us particularly aware about how diseases can easily spread and spread quite rapidly. But it's the zero-dose communities that are particularly vulnerable to allow these outbreaks to propagate and spread because of their low vaccination rate. But in addition to that, these communities are often impoverished, malnourished. I already mentioned how they have poor access to primary health care. So they're more vulnerable to the morbidity and mortality associated with outbreaks. Next slide. So this slide shows the location and size of large and disruptive measles outbreaks over the last year. And it's concerning that there's so many countries currently facing challenges related to large measles outbreaks. And yet we know that most of these countries have large numbers of zero-dose children, which makes them particularly vulnerable. This problem, unfortunately, because of the disruptions related to the pandemic and the immunity gaps that it caused, is likely to get worse as we move forward. Next slide, please. So zero-dose children is central to the global immunization strategies. It's the underlying theme to both the Immunization Agenda 2030 and to Gavi 5.0. Next slide, please. And in fact, both IA 2030 and Gavi 5.0 are very much aligned around this vision to leave no one behind. And the objective of the zero-dose agenda is written as exactly I've shown it here for both strategies. And it's not by coincidence that they've used the exact same wording for both strategies. And the exact words are that the objective is to regularly reach children that didn't receive any vaccination through routine services. So next. So if you break it down, the second half of this statement is about children not receiving any vaccination through routine services. So that's clearly about zero-dose children. But it's the first part that often gets forgotten. And that's about regularly reaching them. That part gets forgotten, and sometimes it gets confused that the zero-dose agenda is about just giving them a single dose of a vaccine or by giving them just a single dose of DTP1. Next slide. But in fact, the zero-dose agenda, when we say regularly reach, what we're trying to say is that the objective here is to fully vaccinate zero-dose children. And in fact, we can even go beyond that and say the objective is to fully vaccinate zero-dose children as an entry point to providing a broader set of primary healthcare services. So just for your information, the goal for the IA 2030 as a 10-year strategy program is to reduce the number of zero-dose children by 50% by 2030. And the goal for Gavi 5.0 as a 5-year strategy is to achieve half that and reduce the number by 25% by 2025. Next slide. So the Gavi Alliance has developed the IRMA framework, which can help conceptualize how the zero-dose strategy can be used to strengthen primary healthcare across the life course. So IRMA is an acronym. So the letters in English are IRMMA, which stands for Identify, Reach, Measure, and Monitor, and Advocate. And if you look at the center of this diagram, you'll see that we've paid particular attention of making sure that the zero-dose and missed communities are at the very center. And that's deliberately done to represent how all of our activities should be centered around these communities and should be community-centric. The Identify component has two parts. The first is to find and describe the zero-dose communities. And the second is to then go to the communities, listen to them, and try to understand what are the barriers to vaccination in these communities. Once the barriers are identified, you go to the Reach component of the framework. And as part of Reach, we need to have tailored strategies based on the barriers identified. And then we must try to integrate services as much as possible and sustain them over the long term. We then need to measure and monitor all interventions. And throughout all of this, we need to advocate with political leaders to help ensure that these communities remain prioritized. Next slide, please. And at this point, I'd like to hand it over to my colleague, Nicholas. And while he's getting online, I could maybe start the question. So the question for all of you to put into the chat is, what types of challenges do you anticipate with identifying zero-dose children and communities? Over to you, Nicholas.
Thank you very much, Samir. First of all, I can see myself. That's good. Good start. So thank you very much. My name is Niklas Danielsson. I work for UNICEF as a senior immunization specialist at the UNICEF headquarters, and I work very closely together with Samir on the implementation of the zero-dose strategy. Now, Samir has elaborated on the rationale for the focus on unvaccinated zero-dose children. The point that once you reach an unvaccinated child and they receive their first dose, their chances of actually completing their vaccination schedules increases dramatically. Now the question is, how do you find those unvaccinated children, or rather the communities where they live, and how do you bring them the immunization services they need? Next slide, please. So the first step is to try to estimate how many unvaccinated children do you have in your country, or in your province, or in your district, or even in your local catchment area. You know the definition. You count the number of DTP1 doses given, and you deduct that from the number of children that you think are born in the area, and then you have the number of zero-dose children. We all know that there are a lot of uncertainties in these calculations, but it's important to try to estimate the number of unvaccinated children you have. The Reaching Every District RED strategy, which is should be on the slide. I can't see it now. Anyway, it has a strategy for estimating or the number of zero-dose children. Next slide, please. Next, you need to think about these communities where the unvaccinated zero-dose children live, the zero-dose communities. What are their attributes? Why are they not reached? Why are they not accessing the immunization services? You go to next slide, please. And then you need to, and then I'll just remind you about the slide that you have seen earlier today, where we have 3 settings: the remote rural settings, the urban poor communities or urban poor settings, communities that are affected by conflict, humanitarian emergencies and insecurity, where you expect to find large numbers of unvaccinated children. And then we have the more overarching problem with gender-related barriers, those social and health system gender barriers that make it more difficult for female caretakers to access and use services, and more difficult for female health workers to influence or design the way services are delivered. Next slide, please. Now, this is really an analytical process. How do you figure out not only where you expect to find unvaccinated children, but why they're unvaccinated and how you can tailor your services to reach them? There is help to get here. There is an online tool called HEAT, and there's also a version called HEAT Plus on the WHO website that is preloaded with national data, and you can use that to estimate the number of unvaccinated children. There is also a WHO guidance or manual called Inequality Monitoring in Immunization Step-by-Step Manual that helps you to understand how to conduct a coverage and equity assessment. And then there is a guidance document from UNICEF that is called Coverage and Equity Assessment, which is more of a hands-on manual on how to organize a coverage and equity assessment and how to present the findings. It even includes a template on how to write the report that will help you to avoid missing important aspects of coverage and equity assessment. Next slide. Now, so the next step is to operationalize a zero-dose strategy after you have identified the communities and you understood why they're not vaccinated. This is often referred to as bottleneck analysis, but there are also other names to this process. Next slide, please. Now, one important part of that bottleneck analysis, because the bottlenecks can be in the in the supply side of vaccination services, whether you have the cold chain to the available so that you can provide vaccines to underserved communities. But it's also a very important part of behavioral and social drivers of uptake of or use of vaccination services. And you can see here on the slide a number of resources that can help you to understand common behavioral and social drivers of immunization. Next slide, please. Missed opportunities for vaccination. I know this was covered in session 1, I think, and it's an important document. Next slide, please. And it is a reminder that missed opportunities for vaccination are really important when it comes to zero-dose children, because opportunities to vaccinate, whether it's in the curative care, whether it's when the child's mother has antenatal care, or whether it's integration of vaccination services into other primary healthcare programs, such as deworming or malaria or growth monitoring, may be the only opportunity that zero-dose children have to become vaccinated. So strengthening or reducing the number of missed opportunities by making sure that vaccination is available in different ways apart from routine immunization in fixed sites and in outreach is an important way to reach zero-dose children. Next slide, please. So we are now deep in the reach part of the zero-dose strategy. You remember that acronym IRMA: identify, reach, measure, monitor, and advocate. And it's really not until you understand and describe the barriers to vaccination in the zero-dose community that you can start planning for the pro-equity interventions and strategies that will increase the reach of the program. Next slide, please. So there are many strategies and interventions that you have at your hand and that you can pick and choose that fits your context or your situation. Periodic intensification of routine immunization, PIRI, is one of them. If you identify that for example, remote rural communities are among the most underserved in your catchment area, that's where you have most of your unvaccinated children, and you also realize that it is unrealistic, at least in the short term, to provide them with regular immunization services, then you may consider a PIRI approach, periodic intensification. So PIRIs aim to provide all the vaccines in the vaccination schedule, and it also requires that you check children's vaccination status, that you record immunization and report them as part of routine immunization. And that's really the difference between a PIRI and a campaign like supplemental immunization activities. Next slide, please. Now, urban poor families, or families who live in urban poor areas, informal urban settlements, we sometimes call them slums, face many and very particular barriers to vaccination. They are usually not the geographical barriers. It doesn't have to do with the distance to immunization services. It has more to do with social barriers and very often with systemic discrimination, that health facilities are not built in the informal areas. It's not possible for the people who live there to access health services in health facilities that are located in more affluent areas. There is a toolkit for urban immunization that tries to address this particular problem. Next slide, please. Now, communities that are affected by humanitarian emergencies and also communities that are affected by conflict and insecurity is a very particular problem in reducing the number of zero-dose children, and it's an increasing problem. A larger proportion of the unvaccinated zero-dose children are expected to be found in humanitarian emergencies and in conflict and insecure areas. And this may be very acute humanitarian emergencies that these two guides are reflecting on, but it's also families and communities that live in conflict areas where government has no reach beyond the provision of government organized health services, and where health services have deteriorated. Next slide, please. So this is a reminder that it is important to take note, to understand that the zero-dose strategy does not seek to reach marginalized communities just once or in very long intervals. The end objective is to integrate and sustain equitable delivery mechanisms in the routine immunization, to tailor your services so that you can sustainably and regularly reach the communities where you have many unvaccinated children, and also strengthen other primary healthcare services and also other social services such as water and sanitation, education and security, that we use the identification of zero-dose communities as a way of finding underserved or marginalized communities. Next slide, please. Catch-up vaccination. I think this is particularly important now when we have seen a large disruption of vaccination services during the COVID pandemic in 2020 and most likely also in 2021. And this is a recently developed guide by WHO how to plan and implement catch-up vaccinations. Next slide, please. A quite particular problem for reaching zero-dose children is that many of them will be detected, if they're detected, late in life, and there are upper age cutoffs that are often implemented not because of policies, but because of practices and internal rules in the programs that make it difficult or sometimes impossible to vaccinate children who are with the first doses of pentavalent and IPV, and if they have passed a certain age, or to give the second dose of measles if they have passed the second year of life. The second year of life resources here provide guidance on the second year of life platform, and also is a reminder that there shouldn't really be any cutoff, age cutoff for children to have neither recovery vaccination or catch-up vaccination during this recovery phase or at any time in the routine immunization provision. Next slide, please. This is another resource guide available to you. It's called Working Together. It's about integrating resources for immunization services throughout the life course of immunization. Next slide, please. This is an illustration. It's very complicated. It's not possible for you to read, but it shows how different what we tend to call vertical programs or disease-specific programs can be integrated in outreach services and the delivery of routine immunization services throughout the life course. Next slide, please. Now, monitor implementation and measure impact. I think this may not be something I need to tell you, but of course, when we implement recovery as well as strengthening services to reach more zero-dose children, it's important to monitor the effect, the impact of the pro-equity interventions and strategies we implement. Next slide, please. This is about home-based records. Home-based records are still at the core of recording vaccinations, and the availability of home-based records is very variable, both in health facilities and households. Very often, families or parents do not have access to the home-based records simply because they're not given one in the health facility when they come for vaccinations. But they are a very important tool to determine, of course, which vaccines children have received, and to find zero-dose unvaccinated children. Next slide, please. Innovations. Now, a crisis is always an opportunity for innovation, and we are in the middle of a crisis, maybe the biggest crisis that the immunization program globally has experienced in ever. And innovations come in many shapes and forms. People tend to think about innovations as technological interventions, such as geographical information systems, the digital maps, so population distribution, digital microplans, the use of smartphones to do real-time monitoring or to send out reminders to parents. But innovations do not have to be that tech dependent and expensive as these things. There are many examples of operational innovations that can be implemented much easier and faster to scale up. Examples include using the campaigns to identify zero-dose communities, to leverage other programs to reach zero-dose communities and provide or identified vaccines or identified zero-dose children. And such a simple things as changing the opening hours, the days and times of services to accommodate the needs of caregivers. Next slide, please. So moving forward, I have demonstrated here very quickly to you a plethora, a large number of guidance documents and resources, and they are already available, but the difficult thing is, of course, to implement them, to find a way moving forward to do this both in the local context and at the national level. The WHO and UNICEF, and of course also Gavi, the expanded partnership, are here to help to develop additional strategies and to help with the implementation and to develop proposals and access funding for these strategies. Next slide, please. On TechNet 21, and I hope you are familiar with this resource, there is now a database, a kind of an inventory of documents of resources that are important or relate to the implementation of the zero-dose strategy. That database is organized along the IRMA framework that we talked about earlier, the identification, reach, measure, monitor, and advocate, so that you can search for resources that will be helpful for your particular situation. And you have the link on the slide. Next slide, please. This is just to advertise something called the Zero Dose Community of Practice. For those who have not yet joined it, it's a communication platform where anyone who is interested in the zero dose strategy and they can dialogue, can talk to people across the world, in other countries and in other organizations about strategies to reduce the number of zero dose children. You have the link there, and if you go to that, you will find the page where you register for use. And I would encourage you to do that because I think it can also help you with your fellowship projects. Next slide, please. Now we are back at that question that Samir asked in the beginning. What is the objective of the zero dose strategy? So we are going to do that question one more time. And let's start now. So we are approaching half of the participants have responded to the question. And maybe we should show the results now, because 2/3 have answered. I wonder if we can compare to the response at the beginning. It's not that encouraging, because many people, 42%, have still answered that the objective of the zero dose strategy is to reduce the number of children who lack the first dose of DTP, the first vaccine. That is the indicator. This is how we measure how many unvaccinated children there are. But it's not the objective. It's not what we want to achieve with the strategy. What we want to achieve is for all children, those who are not vaccinated today, to have all the vaccines, to become fully immunized children or fully immunized child. So that to improve coverage and equity by fully vaccinating all children, and also to use the identification of zero dose communities as a way of for other primary health care services and also for other social services to find their way to these communities and find ways of reaching them and therefore providing services. So I think this is a very, and I hope we can discuss this question a little bit more, because there's a difference between the indicator, and we don't want to program just to reach an indicator. We want to program to achieve the objective of the strategy, which is to ensure that all children everywhere, and particularly those in marginalized and underserved communities, have the protection of all the vaccines in the vaccination program.
Nicholas, may I interject?
Please.
Yeah, so when we developed these questions, to be honest, I anticipated that we were going to have this bit of a split. So I wouldn't be disheartened if you're feeling a little confused by this right now, because we wanted to stimulate this conversation. I would say there's probably one correct answer and one that's probably semi-correct. So the correct answer is to improve coverage and equity by fully vaccinating the most marginalized children. That's the heart of what the zero dose agenda is about. And that's probably the more correct answer. It's not completely incorrect to say it's to reduce the number of children like DTP1, because that's technically the indicator goal that we're trying to achieve. But we framed it this way because we want to make sure that we don't lose the bigger picture here. And that's the concern moving forward. So I'm going to share with you an analogy based on anecdotal experience. Hopefully it makes it a little bit clear, but I'm trained originally as a clinician, as a medical doctor. And I remember when I was working in the hospital, every year, it was a common occurrence that you would find a medical student who would hear the heart monitor going flatlining, beep, and panic that thinking that the patient's heart had stopped and start CPR. Every year you would find a medical student who does that on a patient who is alive, awake, and even talking, and they're trying to do CPR on them. And why is that the case? It's because that medical student is listening to the machine, not to the patient, and they forgot to talk to the patient. And similarly, in our public health programs, we need the indicators, just like we need the machine. We need these as tools to guide us. But if we become so fixated on them, we lose the bigger picture. And we don't want to be like the medical student who's trying to do CPR on a talking person who does not need CPR. We want to make sure that we don't ever lose sight of the bigger picture. So by all means, we definitely want to try to follow the DTP1 as an indicator moving forward. But it's, to be frank, not going to be 100% reliable in all settings. So we need to think outside the box and never forget what the underlying objective is, which is to fully vaccinate these most marginalized communities and children. So I don't know if I made it more confusing or more helpful, but hopefully that helps clarify it a little bit.
I think you made it much more clear, and I think if I try to reflect a little bit on it, I think this is a very important shift actually, because immunization programs have for a very long time been the public health program that has reached most children in most low and middle income countries. And because we have a good way of identifying underserved, marginalized communities, and we reach so many children, we have in a way a responsibility to make use of that marker of marginalized communities to help direct other programs, other primary healthcare services, and other social services in the same communities. And this, I think, is an important shift that we hope to see with IA 2030 and also with Gavi 5.0.
So Liz, I think we go to questions now, correct?
Yes, that is correct. And I know we've received several through the chat, and again, would encourage folks to continue to ask their questions in the chat box.
And while we're waiting for those questions to be pointed out to us, I just wanted to highlight, I saw multiple times in the chat mention about some of the web links were not working, and our apologies, that's correct. That's because WHO just a few months ago changed their server. So a lot of our website links have changed, and we did not update some of these slides, unfortunately. We thought we had, but apparently we did not fully do that. So when we make the slide set available to all of you through Boost, we will make sure to update all of those links. So our apologies, we did not anticipate that, but we can fix that fairly quickly.
Great. So I think I might hand things over to Laura and Jill Mill to read out maybe one question at a time.
Yes, hello, everyone. So the first question is really a clarification question where Maza Mao is asking, and the question is in French, but I read it in English. If I have understood correctly, for a zero-dose child found at an advanced age, the entire vaccination schedule must be repeated as from birth.
So, I would say that you would have to follow the guidance from your country in terms of their recommendations on what vaccines to provide at a given age. But the point we're trying to make is the goal is to fully vaccinate the child as much as possible. And the hope is to bring him into the system, not just to have a one-time visit. So you provide all the vaccines that they're eligible for at that time of visit. And if it's to complete a series, they may need to have follow-up visits and come back. But whether they need all vaccines, well, it's dependent on the guidance from your individual country and their catch-up vaccination schedules. From a WHO point of view, certain vaccines like rotavirus, for instance, we do not recommend giving after 2 years of age. So if that child comes in after 2 years of age, we're not recommending that you give that vaccine because they're no longer eligible for that vaccine anymore, and it does not give them much benefit at that age. But the goal, the big picture here, the goal is we're not trying to just give them one dose. The zero-dose agenda is not a one-dose agenda. It's about fully vaccinating these missed communities. And so that is the ultimate goal.
Okay. And so there's another clarification. Is zero dose only focused on marginalized and underserved communities?
No. So let me take that. Now, when the objective, as we said, is with the zero dose strategy is to vaccinate all children with all vaccines. But the unvaccinated zero dose children have been the most resistant over the last 10 years or last 20 years in immunization programs. The proportion of unvaccinated children who never start vaccines or never come in contact with the vaccination program has been more resistant to change than the proportion of children who start and do not complete their vaccination schedules. That group has shrunk over time, while the group that are not vaccinated at all has been resistant. And that the fact that if a child comes into contact with the vaccination services, has the first dose of vaccine, their chances of having all the doses goes up dramatically. So that's why it's so important to try to reach the unvaccinated children. Now, there are unvaccinated children everywhere in the country, but they tend to be concentrated in certain communities. And those are the communities we call marginalized or underserved. It's really the name. The name is really, the different names are really for the same kind of communities. Population groups that are not reached by our services because either they're systematic discrimination or because they simply live too far away, it's too expensive, the marginal costs are too high to reach them, or they are discriminated because they are not citizens of the country, they are refugees, or they belong to a certain religious group, and so on. So the focus of the strategy is not only on this group, but there is where you have the biggest gains. If you really want to, as fast as possible, reduce the number of unvaccinated children, those are the communities that you need to focus your attention to.
And Jim, if you don't mind, I know you or Laura were going to ask the next question, but I see one question that comes up a few times in the chat. So I thought I would address it now, if that's okay. The question that I keep seeing is, why is it DTP1 that's considered the indicator? And it's an excellent question. It's important to remember that that's the indicator for us to monitor at a global level and potentially a national level. And the rationale behind it is, again, remember what the objective is. It's for us to identify those populations that are not having access to routine services or not utilizing routine services. So after looking at various possibilities at which vaccine was best representative of that, it was found that DTP1 was the best for multiple reasons. First of all, it's universally in all countries' immunization programs, as opposed to BCG, which not all programs offer BCG. Not all programs, unfortunately, are offering birth dose of hepatitis B either. So it's hard for global monitoring if we can't have a vaccine that's available in all countries. That's one reason. The other reason, because the question comes up again about the birth doses, is depending on your setting, the birth dose might be not offered through the typical immunization program route. It might be offered through the institution, if it's institutional delivery, it might be offered in the hospital, which is very appropriate. But if you're trying to monitor access to services, we might be missing some part of the population that gets that birth dose, but then subsequently does not get access to the routinization services subsequently. So taking all those considerations and limitations, for global monitoring, it was decided that DTP1 was probably the best indicator when you combine also the fact that it's a fairly convenient indicator. It's already being collected. It's not hard to measure since we already collect DTP1. You could theoretically, if you want to take the zero dose meaning very literally, it would not be wrong to look at zero dose of all vaccines. It's not, from a technical point of view, wrong to do that, but it's very difficult to monitor when you're down at the program level. So for convenience sake, DTP1 was found to be the best that kind of matches all of the needs that we have for monitoring purposes. Now, with that being said, I'm going to emphasize again, this is what was decided for global monitoring. I think it's fair to expect it for national level monitoring as well. But when you get to implementing at sub-national area, you're going to have challenges using DTP1 administrative data, unfortunately. Some settings, you may have over 100% coverage of DTP1, but you know there's zero-dose children in those communities. So it's going to be very difficult to implement if you fixate on DTP1. And that goes back to the point we had earlier, that if you keep in mind what the objective is of the zero-dose agenda, which is to identify those communities that are lacking access to services as your priority communities, you don't have to be so dependent on DTP1. You should still use it, but if it proves to be an unreliable indicator, you should triangulate with other indicators available. So for instance, if you have measles outbreaks in your community, that might be an indicator that you have zero-dose children in that community, for instance. And so we have this term measles as a tracer to identify the populations most in need. We have done now multiple studies, and we have found that these communities that we're trying to identify, these zero-dose populations, as I showed in my slides, there's a correlation with access to antenatal care, with maternal tetanus vaccination as well. So if you have reliable indicators that show that as well, that could be a proxy indicator for those zero-dose communities as well. Places where you have lower rates of antenatal care or institutional delivery might be a proxy indicator for zero-dose as well. So we want you to use all of your data and not fixate on DTP1, because if you do, you'd be, sort of like that medical student doing CPR on a living patient. You don't want to do that as well.
Thanks, Samir. I don't know, Nicholas, if you want to add to that. We'll go on to the next question.
No, let's go to the next question. I think Samir covered that very comprehensively.
Great. No, this has come up a couple of times in the chat, and I think people are asking, is there any specific methodology to estimate the number of zero-dose children, or a formula for estimating the proportion of children with zero-dose?
Well, the formula is simple in a way, saying that if you count the number of DTP1 doses you're given, and you deduct that from the number of children who are born in the same area, you should get the number of unvaccinated children. We all know that there's a lot of uncertainty in these numbers. And although the figures are quite reliable on national level, because when you aggregate data, they tend to even out, can be very difficult at local level, at district level and sub-district level to do this. And it's really necessary to do a lot of what we call triangulation, to look at different sources of data. I think maybe the most typical one is that health facilities or district tend to rely on expected number of births that they are given from higher level, and those expected number of births are based on projections from census that can be 10 years old or older, and be very inaccurate because of movement of populations and migration and so on. So it's important to try to look at other sources of information as well. One of them is, of course, to do head counts, to try to estimate how many people live in your catchment population. Also to look at information from other programs and to look at trends over time, because you would expect to gradually increase the absolute number of vaccines that you give every year to see if you're improving. It is a difficult task, really, to do this estimation of number of unvaccinated children. I think it's also important not to be too hang up on it. It's the exercise of trying to find out which communities in which communities are you likely to find unvaccinated children, to look at the social determinants of vaccination, whether they are on the supply side of the vaccination programs or they are on the determinants in the communities themselves, whether they are able to access and use the services, are probably more important than focusing than becoming too obsessed about trying to find the most accurate estimate of the number of zero-dose children. So Samira, I think you probably have things to add to this discussion on how to measure the zero-dose children.
Yeah, I mean, if you want looking for a formula, I think I'm putting in the chat. I'm putting off the top of my head, so hopefully I didn't get it wrong. But it's basically taking 100, subtract the DP1 coverage from 100, multiply that percentage by the target population, and that give you an estimated number zero-dose population. So the formula is not difficult. The challenge is just the reliability of your DTP1 indicator. That's where we really have challenges. And if you're depending on administrative data, we all know that that's particularly challenging. If you have survey data available that's fairly reliable, you think, then you could use that as well. The challenge, of course, with survey data is that you can't do that frequently. So you do that maybe once every few years. It's hard to monitor the progress. So that's why we're really encouraging you to triangulate your data as much as possible. Use your other data sources and not forget what the objective is. So if you can have other ways of identifying which are these neglected populations, rely on that, then you're not obligated when you implement to have reliable DTP1 data to guide you. If your DTP1 data is reliable, by all means, you should use it. But if it is not, we are actually encouraging you to be flexible and try to find other ways to identify these same populations.
Yeah, and maybe a good example is that there are many health facilities and many districts that will find, using their administrative data, that they have about 100% coverage for DTP1. That is not a reason not to not look for zero-dose communities, because we know that if you have more than 100% coverage, it's not because you have vaccinated every child in your catchment population. It's because most often you have an issue with your denominator, with the number of children you're supposed to reach.
I still see questions coming up in the chat as to why not using birth doses as the indicator for zero dose. And it's a good question, because you would think logically that would make a lot of sense. But for global monitoring, the birth doses aren't as practical for us because those individual vaccines are not universally offered in all countries. So it's hard for us to monitor globally if we're looking at birth dose BCG in one country and DTP1 in another country and birth dose OPV in another place. So we want to have a consistent indicator that all countries are able to offer. And then the other issue is a lot of those birth doses are offered at the institutional delivery site, which is great and important, but it may not truly reflect access to routine immunization services afterwards. So if you want a better sense of having access to routine immunization services in some settings, DTP1 might be better. But again, this is regarding global monitoring. Now, if you're at your local level and you feel at a local level that birth dose is more reliable to you to find these priority populations, by all means, you should be using that data as well, because we want to triangulate. It's whatever allows you to identify our objective of finding these neglected or marginalized populations, and then moving toward those interventions. One concern we've had in the last year as this agenda is rolled out is that I think there's a lot of confusion on this identify component and these indicators, to the point where we think, or we're concerned that places are paralyzing themselves to move forward with the implementation of interventions. You may already know where these priority populations are, but the DTP1 data may not be pointing that direction because it's not so reliable. But you know this population is neglected. You don't need to rely on it that way. I mean, you can depend on your other indicators that point to that fact that that population should be prioritized. And please, by all means, begin interventions to try to serve those communities.
So moving on to interventions. So there was a question by Dr. Attila Nosongo. Sorry if I pronounced your name incorrectly. And the question relates to for children living in conflict areas, and what is the strategy for these children?
Yeah, let me take that first. It is reaching children in conflict areas is very, very difficult, and it's also a new challenge to immunization programs, but a challenge that will become more and more important because a larger proportion of the unvaccinated children actually are unvaccinated because of conflict and insecurity. Now, conflict and insecurity affects, of course, both the families themselves, the communities. They cannot move to the health facility, they cannot move to the outreach place for a vaccination program, but it also has a lot of impact on the health services. The health facilities get destroyed, no one wants to work there. The people, the nurses who work in the health facilities don't want to live there because there is no schools for the children, it's insecure, you're at risk of being raped and so on. So it is really a formidable challenge. Now, there is also a lot of experience, and maybe particularly from the polio program, because polio has been retractive in conflict areas, how to negotiate access to communities that are often outside of government control, and to negotiate with parties that are in control of those areas. And that is maybe one of the more important things, how to negotiate access. And another thing that has proven to be very important is that and that's an important lesson from the polio program as well, if you try to reach those children or those communities with only one intervention, only one vaccine, it clearly becomes very quickly becomes kind of hollow for the communities, because they are in much more need than just OPV drops, for example. They are in need of many different health services. And one of the more important strategies is to try to integrate many primary healthcare services into one when you access the communities affected by conflict. Another important strategy is to contract or liaise with local civil society organizations or NGOs that often have better knowledge about the area, better contacts, and are able to reach the communities that are beyond regular health services and beyond government, in areas beyond government control. Over.
I'll just add that, that what Nicholas just mentioned here about the partnership with the local CSOs and non-government organizations is a key part of our thinking here with the Immunization Agenda 2030 and also with Gavi 5.0. Both of these global immunization strategies are putting extra emphasis over the next several years to expand our partnerships. It's a core principle of the IA 2030 to be partnership based. And what's meant by that is that when we go to these difficult settings, such as in conflict affected areas, we can't realistically expect the public sector alone to be able to do it. We really need to partner with the local communities, the local NGOs who perhaps have better access to those areas, perhaps have better trust with the community as well, to help us deliver those services as well. So I think that's going to be a key element moving forward. But unfortunately, it's going to be there's no easy way to say this is the way to deal with that issue, because each scenario is so unique. You got to take into consideration the local context to come up with strategies moving forward.
So Liz, I think we've covered most of the questions. If you would want to move to some of the information about the next sessions. Thanks.
Sure, I can definitely do that. I don't know if we might have time for just one more question, if there's anything else coming up. If not, I can move on.
Yeah, there's still some confusion about the indicators, but maybe written clarification might be useful. We could probably give the floor again to Samir and Nicholas. Other than that, there were some questions related to the presentation that Laura made earlier regarding the template, where people were asking about the timeline and some of the specificities. So as Laura mentioned, we will share the template by the end of the week, and we will also provide the timeline and more detailed information. So if you could just wait a few days to hear more about it from us. Thank you.
Great, thanks so much, Jamil. MJ, if you could go to the next slide, please. So the reflection question for this week is, what can you do differently now to identify, reach, and fully vaccinate zero-dose children? Again, we will post this question in both English and French to the forum in the Boost Learning group. So we do encourage you to visit the platform and post your responses there, along with commenting on some of your peers' posts as well. Next slide. And just a note that next week's session will take place at the same day and time on using immunization data for action. Next slide. And also just wanted to show you some of the upcoming sessions that we have. We did make a switch to one of our sessions on publishing your results, which will come a little bit earlier. And that's just swapped out with the comprehensive session planning. But we still plan on the same cadence of sessions. So do plan to put all of these dates on your calendar so that you can attend these sessions. Next slide. And then again, just a few reminders. One, please do take our post-session survey. Again, we ask that you fill out the survey after each session so that we can provide feedback to our facilitators and improve along the way. And I believe that link will be shared in the chat, and we'll also send it in a follow-up email. If for some reason you're not receiving our emails, please do reach out to us at info@boostcommunity.org so that we can add you to our mailing list. Again, in the Boost Learning group, you'll find all of the resources from today's session along with previous sessions. So both the recordings, the slide decks, and the Q&As for every session in both French and English. We're also using our fellowship Telegram channel for some quick reminders when sessions start. So we do encourage you to sign up for that channel. And then again, a reminder of next week's live session on using immunization data for action. And if you do attend all of these sessions and fill out the post-session surveys, we will award you with a certificate of completion at the end of the live engagement series that will conclude at the end of June. Again, for those that are doing the mentorship program, if you participate in that program through its entirety and submit a final report, you'll receive a certificate of achievement, which again, we noted at, I think during sessions 1 and 2, but we'll also recirculate that information once more, along with, as Joma mentioned, the template for both the strategic proposal and case study. I think that's it from my side. I just want to again thank Samir and Nicholas for their great presentation today. And again, thank all the participants for asking your questions. And we look forward to engaging with you next week. So until then, have a great week. Thank you, everyone.